On one of my clinical experiences, we got a code situation where the ambulance had like called ahead, so we knew they were coming, and it was a pretty slow day. I don't think I was supposed to be in the ER, but since it was slow, they let me go down and watch. And I guess the situation was that there was these two guys, and they were sleeping in their truck. And mind you, this is at like I think it was at like 5 o'clock in the morning. I was there super super early, and it was like right at the beginning. They'd been sleeping in their truck. One of the guys got out to go to the bathroom. And when he came back to the truck, he had been stabbed like 3 times. And so they brought him into the hospital, and there was blood everywhere. He was like totally conscious, aware of everything. He looked like nothing was wrong except for there was blood spewing out of him. Other than that, he was like super coherent. Um, the doctor, he wouldn't tell anyone his name or anything. He wouldn't really speak to anybody, but clearly he had been stabbed. And all of this story came from his friend that had dropped him off. And so they ended up inserting a chest tube into his side to help relieve some of the blood that was pooling up. And that was an experience that I don't think I'll forget. First of all, the sound from inserting a chest tube, it's not a quiet thing. At least that one sure wasn't. And it was like a balloon popping almost type of, I don't,
Hmm.
No
um,
idea. I've actually never been present when they've placed them. I've just helped with maintenance
dude,
afterwards.
it was like, I don't, I'm trying, it was a while ago. I remember the sound just being like, whoa, I wasn't expecting that. And, and the force that the doctor was using, like, I always thought it'd be very gentle, but you could tell like the doctor was like using his muscles and like really pushing hard, and then it like popped through, and not what I was expecting at all. um yeah.
Yeah, chest tubes are pretty wild. You know that's a pretty classic example of like one thing that you can use chest tubes for. Hemothoraxes are pretty serious things to consider, and chest tubes are like the primary way to get rid of that fluid. But my experience with chest tubes is I was on one of my first clinical shifts. I had the ability to go down to the ER and watch a drug overdose patient that had a pneumothorax. Um, they they had to insert a chest tube to, of course, get the air out, and it was a very similar experience. It wasn't like a balloon popping sound for me. I think that might have been just the pressure from the fluid for yours. But it was kind of like you could hear the air rush out when they inserted the tube. It was interesting. But yeah, they use a lot of force to get the tubes in because you want that tight seal. You want the pleura to really hold on to the tube while it's in there while they get it sutured in place. It's a really wild surgery, but it's one of those things that us as respiratory therapists are a huge part of when they do these surgeries these for emergent conditions is we need to be there to manage their airway and make sure they're breathing appropriately while they do these procedures and be there as support if they start to crash and begin to code. It's pretty wild, but the placement of a chest tube is one of the more common, I'd say, emergent procedures we do. Pneumothoraxes are pretty common in certain patient populations. I mean, there's tons of different reasons they can happen. Um, and actually, Drew, do you want to go over and discuss some of the different reasons a pneumo might happen?
All right, so pneumothorax, it can happen for various reasons, but what it is at first is just somehow your body has taken on air that has entered between the space between your pleura and your lungs, and this air starts to put pressure inside your chest cavity or within that pleural space, I mean, and it starts to encroach on that space of the lungs, and so your lungs are not able to fully expand like they're supposed to because they have that extra back pressure that it doesn't normally have. Um, and this can happen through various ways. Like we were just talking, where this guy had just been stabbed so many times. You, because of that foreign object that has now introduced air and a way for air to come into the lungs. There are also things that make you more susceptible, like being super tall and skinny. Um, it puts you more susceptible for whatever reasons to how that air, for whatever reason, enter your lungs. Like if you sneeze or something and you just happen to rupture maybe an alveoli or something that just ruptures and then helps that air to enter your lungs. Um, and then also like drug overdose, anything that might make your lungs a little bit weaker as that air starts to kind of seep through, and I guess lack for better words, just kind of just bleed through your lungs and enter that pleural space. Um, and then just really anything that can kind of can basically enter your body as well. Can sometimes just let that air leak into your body and then create that back pressure within that pleural space to start to expand and encroach on the space of your lungs to um, not let you breathe as much. And a lot of people, I mean, actually, almost everybody, it gives a lot of the sense of just you're short of breath because you're not able to expand, you're not able to oxygenate your body as much when that air starts to enter your lungs because the gas exchange happens inside of your lungs, not on the outside of your lungs.
That's crazy. Inside the lungs, not outside.
I
I'm
know,
just,
right? It's
I'm just kidding,
crazy.
Drew. I think it's also important to bring up that as respiratory therapists, we can harm patients if we're not careful. Like we can cause a pneumothorax, especially when we're like managing ventilation of a patient. If we have like the pressure too high, even if we have like normal settings, we might be able like might accidentally cause a pneumothorax on these patients because their lungs are just really stiff and have low compliance. Um, so yeah, we need to make sure that we're doing what's best for the patient and assessing them so we don't allow harm to happen.
Oh yeah, that's a huge part of our job is ventilator management because each patient is different. Each patient has different lungs, and while we can attribute some normal values to just kind of give us a baseline, it really is different from patient to patient, and we want to avoid giving them any barotrauma, which is just pressure trauma. Um, we want
But
to
yeah,
avoid that.
like because that kind of goes along with other things that could cause a pneumothorax, like broken ribs. You can puncture a lung with just like loose bone fractures in the thoracic cavity. Um, flail chest is kind of a common thing. Usually, this happens with I don't know. I'm just trying to think of an example. I would say someone like a roofer is like reshingling someone's house and they fall off a roof. That's considered barotrauma, like having a fall from a like a high place kind of thing. And yeah, so with like flail chest, you have broken ribs on like one side, and like Drew was saying, the pressure difference can affect your respiration because we breathe pretty effectively running on a negative pressure loop. But when you have a flail chest, it changes the pressure. It's kind of hard for your for everything to work properly. You have paradoxical breathing, which means like your lungs kind of like in that area where you have the flail chest. It's almost like when you breathe, it like concaves in, and sometimes when you exhale, it like pushes it out. Um, it's been a while since I've seen a flail chest. I might have the breathing backwards, but that's an example of paradoxical breathing is like your lungs are just being weird. Like there's an opening and they expand out in that area and then they sink in that area as well.
Yeah, I think
And most of these,
I think that is defined like a flail chest is defined as like two or more ribs broken in like two or more places. Might be three or more.
Right.
So
Yeah,
there's like
it's
a floating piece of rib almost that's broken off, and it. If you think about like the pressure, it's gonna suck in because nothing's holding it in
Right.
place.
And it's totally like our bodies are really amazing, but a lot of the time our bodies, they don't like to fight things. So especially air and like gases and stuff like that, they follow the path of least resistance, and that's what causes that sucking in and expansion um, to present itself in those situations. But a major reason, like a major thing to treat these, we've said, is like you could place a chest tube that helps evacuate some air or fluid that's trapped in someone's thoracic cavity. Like Trevor and Nick were saying, they had stories of witnessing those being placed. I haven't, but I've been in my line of work as a CNA. I've helped manage that. Some things you want to look for is you want to make sure most of them it's a three-chamber system, and it's usually like this rectangle box. When it's hooked up to suction, it's normal for a little chamber. I think on like the bottom left, usually. I think it depends on like what brand you have, but what I've always seen is the bottom left corner. When you have suction hooked up, it should be bubbling in that small chamber. That's normal. So don't be scared when you hear bubbling going on. And then there's like three separate chambers, and that's where the fluid goes from the chest tube. That's where that collects from. Um, I work on an intermediate care unit, which is kind of like it's not as critical as an ICU unit. It's just a step down from there. I think they might have different normals, but what I was taught is if that chest tube fills up more than 500 mils in like an hour, then that's crazy. Like that's a high amount, and they should probably go to the ICU. I don't know if they have that same feedback in the ICU, but you do want to monitor output very closely. Nurse more so does like assessment of the sutures and the stitches that the doctor placed when they performed the chest tube, and there's usually like a bandage over it, like an occlusive dressing, which allows some air to get into that opening. But we don't want to just leave it completely open to the air because that could affect our pressure as well. So those are just some things when referring to pneumothorax or chest tubes that I just wanted to share.
oh yeah, and pneumos are when we have you know a bulk of our patients in the emergency department that we will see as respiratory therapists are usually trauma patients. They're pretty common, sadly, but we're there with pretty much every trauma to you know help manage their airway because these patients might be they might be unresponsive due to shock. And of course, in that case, we need to manage their airway and ventilate them through a ventilator, of course. They might have a pneumo due to trauma. Have They could have a flail chest. These trauma patients that we'll see are in critical conditions, and we are one of the largest parts of the care team to help treat them. I mean, when there's any concern about cranial pressures or neurological damage in these patients, we are a main part in their treatment plan because these patients have to be ventilated through a ventilator, and we need to set that up to reduce intracranial pressures as much as possible. So you'll frequently, if you ever have the opportunity to go into a neuro ICU, um, you will see all these patients on ventilators that have these super high respiratory rates but low tidal volumes, and that's just to help limit the amount of pressure we're putting on the blood vessels and to help then thus limit the amount of fluid that's reaching the brain. So yeah, with those traumas, we're really in there, helping them. And with the more advanced traumas, we of course have to you know go through the intubation. And while we may not be the people intubating at facilities, it's important that we know how to do it in every piece of equipment that we need to use. So, Trevor, you willing to talk a little bit about intubation?
Yeah, sure. A lot of the times we see like trauma patients on a ventilator. There's a couple things that must happen before they can be on a ventilator. Um, the biggest thing is that they do need to be intubated. Without a ventilator, without being intubated, they can't really utilize a ventilator like it should. Uh, I've been fortunate to see a couple of these in my clinical settings. I've never done one on a real live person. Um, but most of the ones I have seen have been in a pretty controlled environment where the patient's declining very quickly or they're not, um, needless to say, it's not like they need to be intubated immediately or they're going to die. We have a little bit of time. And so the doctors have been able to kind of teach a little bit while they do it and do it slowly, which has been really cool. Um, but it's interesting to see these things done because they do in the ones I've seen they've taken their time. They usually sedate the patient, get them on some medication so it's a little more comfortable for them. Granted, these patients are not doing very well, so they're not like all there anyway, but they can at least get it a little bit more comfortable. I've seen it both with like a typical laryngoscope and also with like a glidoscope where the camera's on the end so they can like see down into their airway and into their vocal cords, which have been really cool. Um, and then I've assisted on all the ones that I've seen where I was a student, but they allowed me to kind of help, and I was able to like bag the patient beforehand, which we just upped him up to 100% oxygen, get him super oxygenated before we take it all away for a minute. And then as the doctor intubated, he gets the tube in, and then we put on like a little CO2 detector just to make sure that we are in the right place. Sometimes it's easy to get into the esophagus where it goes down to the stomach instead of the lungs. And that CO2 detector helps us realize where we're at. And then they inflate the cuff and well, they kind of do those simultaneously, but they inflate the cuff and we're able to ventilate the lungs pretty well. And one of the things that was interesting in my clinical rotation, I don't know if you guys have seen an intubation or whatnot, but the doctor requested as he was like listening to the breath sounds to make sure we were in the right place. He like requested me to like squeeze the bag 3 times really fast so that he could like hear the lungs. Have you guys seen that before?
Yeah, I one of the times I've gotten to help out with the intubation, I didn't know it was actually to hear the lungs better. What the physician that was intubating was actually looking at, from what I thought, was to see that condensate in the tube. But it makes sense that just by doing 3 quick inflations, you would be able to, you should be able to hear the lungs a lot better than if you were just normally bagging it.
Who
Have you
knows?
guys?
Maybe it was to do both, to
Yeah.
see the condensation and hear something.
Um, One of the intubations I saw, I'm trying to remember the name of it. It's the long tube. It's like a almost like a tube exchanger.
The bougie?
The bougie device. Have you guys seen one of those we used to intubate?
No, not yet.
Like
So I saw one
to
that
change out a tube, I have, but I
this
haven't
one
seen it.
this one was used to actually intubate because the lady we just couldn't get into her airway. Like it was so weird because we could like he was using the glidoscope and he tried like 2 or 3 times and just every time was like you would watch it borderline. I swear I watched it go in through the vocal cords and then it was like in the esophagus. And so it's like,
Weird.
what's going on? He finally used a bougie device and then it just like slid right down in there. It was super slick, but
Crazy.
that was cool too. and not every intubation goes smoothly. So sometimes those like bougie devices or a glyoscope is used to help make those go a little smoother. And even then, with those devices, sometimes it's just not feasible to intubate the patient. And when you can't get a tube down their throat, you have to find some way of ventilating them, and that's when you lean towards like inserting like a trach, where you actually cut a hole into their esophagus from the outside of their throat. Oh, not esophagus, sorry, trachea from the outside, um, to be able to get that airway.
Yeah, sometimes it's required emergently, or other times you'd put a trachea in as if you suspect like a patient is gonna be on a ventilator for a long time, or like need that assistance. I think it's just more comfortable for the patient than having a tube down their throat and patient being sedated majority of the time. Because the first goal after you secure an artificial airway is to get the patient off of it somehow. So that's our overall goal, is to improve ventilation and so the patient can do it on their own. And by considering these other options, it helps us to help the patient not be vent dependent is something we're worried about, which means the patient kind of gets laxed with their breathing because the machine's been doing all the work for them. But there are some. I was involved with a sticky situation when a doc, um, he didn't. I don't feel like he reviewed the chart very well, because this patient was on blood thinners, and to secure a trach, you pretty much have to cut into the trachea. So when he did that, the patient was just bleeding and bleeding and bleeding and bleeding, and he just kept telling the nurse to replace the gauze. That was when I was helping with this patient. It was me and this nurse. We were changing out the gauze probably every hour, like it was fully saturated. And then eventually an ICU doc came and checked on this patient and jokingly said, "Hey, if rehab will take them, yeah, why don't you just send them to rehab?" I was picking up on his sarcasm, but the nurse didn't. So this patient ended up going to rehab, which is like a less acuity floor than what we have. Anyways, her trachea and all the bleeding, she threw a clot, pretty much like occluded the trachea that this patient had. So it turned into an emergent situation. We instantly transferred over to the ICU at that point. The doc, who thought he was being funny by his sarcasm, he used a scope to assess the situation. So he stuck a camera down the trachea or down her throat, um, and saw that there was all this bleeding going on in there. Luckily, at this point, it had been long enough since she had an anticoagulant that she actually stopped bleeding for the most part. But we had to clean out all the clots, and like kind of like scabs that were developing in there. He pretty much just took out the old trach, cleaned her out, and then replaced a new one, and everything was fine at that point. But yeah, that was kind of a scary situation with the amount of blood that the patient was like perfusing. So
Yeah, that's extremely scary, honestly. You
yeah,
know, those one of the biggest concerns when it comes to artificial airways, both ET tubes and trach tubes, is that they get clogged for one reason or another, and at that point you usually have to replace them. I also have a kind of scary story involving a trach. We This was a pediatric patient, but we me and my preceptor were going around doing our rounds, and we were called to this patient's room that we hadn't seen that day. And what appeared to be happening is she had copious secretions. Like, we would suction and suction and suction down her trach and constantly get mucus up in like copious amounts. But what we think was happening is the secretions adhered to the bottom of the trach and formed a ball valve, um, which basically, for you viewers, uh, a ball valve is a valve that lets something go in one way but not out the other way. So we thought this was happening to her. It wasn't like a standard mucus plug where the airway was completely blocked by mucus. We could pass the catheter in and suction, but she wasn't like coughing anything up, and she was desatting constantly. Um, so what uh what ended up happening is, my preceptor figured out the only way to fix these clogs, usually, is to replace the airway. So that's what he began to do. He got his spare trach and one that was one size smaller, and got ready to change it out. And he took the old trach out, and the suffice to say, he couldn't get the new one in. Uh, what ended up happening, is at some point her trachea actually dislodged itself, so the cut into the trachea was far lower. It was like 3 inches lower than the cut into the skin. So, and normally those two openings are supposed to be lined up so you can get that trach in, but it was super far down. My preceptor actually had to do the unspeakable and stick his finger in there, of course gloved, to find the opening, and get that new trach in. But artificial airways can come with tons of emergent situations that, you know, you try your best to prevent, but they just kind of happen sometimes, and it's always unfortunate when they do, but it's a learning opportunity. So yeah, a lot of artificial airways are a huge part of like trauma situations and just protecting patients. But while traumas are, a common sight in the ER, something that's much more common for respiratory therapists in emergent conditions, is you know COPD and asthma exacerbations. Drew, you have a story from my understanding.
Yeah. So, um, working, I work actually at the same hospital as Thomas here, but one of there's one night I came on shift and I noticed that there's a guy that actually I was taking care of. He was on continuous BiPAP, and that night I was actually talking to the respiratory therapist about like what their treatments were, like why they were doing what they were doing. Because I just never really heard of someone being on continuous BiPAP, meaning that he was always on it no matter what. But I guess he just had so many COPD exacerbations, in a sense where his COPD, it kind of just obstructive lung disease that affects your lung compliance and ventilation. But his has been getting so bad over the years that just standard oxygen wasn't giving enough ventilation. He actually now needed ventilation support, but wasn't to the point where he needed um, necessarily to be have a tube shoved in his throat or a trach or anything like that. He just needed this continuous BiPAP to help keep open his lungs and blow off that air that his body or the CO2 that his body was producing. And so it was just interesting to see, because he came in with the COPD exacerbation, and then because of the deterioration of his lungs that the COPD was causing, he was now having to live off of a BiPAP machine. And I thought that was pretty interesting to learn um, that exacerbations like this can end up kind of a lot of making the patient have to use this extra support just to maintain a normal work of breathing.
So,
I
for the listeners at home, Drew, could you explain what a BiPAP is a little bit?
Yeah, I'm sorry. So BiPAP, it gives dual pressures. So I'm sure a lot of you either have a CPAP or know someone who's on a CPAP machine where it helps kind of keep their lungs open, so that they can ventilate like they're supposed to. whether they're asleep or just kind of need a little bit of help or whatever. But BiPAP, what it does, it has dual pressure. So not only do you have pressure from your inspiration, like CPAP helps out with, but it also gives you support while you're exhaling. And that's kind of why they call it the BiPAP, where it's just like those two modes of ventilation that it's the machine is helping you out with.
All right,
Uh,
cool. Thank you. Trevor, before I so rudely interrupted you, you were saying something.
I got to see this too. In one of my clinical rotations, we had I can't remember if we were like paged to the room or I think we were just even walking by the room, and this patient was on the side of his bed, sitting up with his hands down on his bed, and he was like kind of hunched over and just like breathing so fast and so heavy, like he was just like he had just got done running a marathon or something, and he was super out of it. Like you could see he was like pale and sweating, and just breathing really heavily. And he'd been a smoker. He had COPD, and everyone kind of rushed into his room as they saw him. He was in the middle of getting set up for dialysis too, which was just one more thing added on to the whole situation. And the doctor was like kind of freaking out, but definitely maintaining control. Maintain. He was like kind of trying to assess the situation because it was almost to the point where we needed to intubate this patient because he clearly was not able to breathe. And we grabbed a BiPAP machine and put the mask on him and like cranked up the pressures so that he was to make it easy for him. And at first he was kind of fighting it, trying to breathe with the pressures, but as we talked to him, we're just like, just calm down and just breathe with those pressures. They're meant to help you breathe in and out. So just go with the flow and let the machine do the work for you. And after about 2 minutes of that, you could see his appearance just totally like relax. He was breathing much more comfortably. He quit sweating. He got color back in his face. And then he was able to get off the BiPAP, and then he was totally fine. He had just like freaked himself out pretty much after he started kind of like getting short of breath. Then he just kept freaking himself out more and more and more, and it just escalated the whole thing. So we put him on that machine, and then he was kind of able to calm down and maintain control of the situation. But it was scary because he almost got intubated that day.
Yeah, no, those COPD exacerbations are super scary, and I don't know about you guys, but I feel like a majority of COPD exacerbations I have seen are, someone that came in, BiPAP didn't cut it. They're like end stage COPD, and like heavy smokers, but they always seem to have to be intubated and kept at the hospital for like a week or two.
Yeah. And they're hard to get off the ventilator once they are intubated. It's like, oh, you don't want to because they're so much harder to wean off of a ventilator.
hmm Yeah, but sometimes that's the only option, and
Yep.
is what it is. But thankfully, there's also for both asthma and COPD exacerbations, we do have medications we can give them to help. I mean, ipratropium bromide works wonders with COPD and asthma. And for you listeners at home, it's what's referred to as a backdoor bronchodilator. Um, it is a short-acting beta agonist that works on a different mechanism than albuterol in what it actually affects um, on the beta receptors. So it works. It has the same effect as like albuterol, but it does it in a different way. So you can give it combination with albuterol for greater effect. So and what both those medications do is they just dilate the bronchi and just make it so they have more airflow going through them. Um, my experience as a asthmatic, I've had uh, two asthma exacerbations in my life that I've ended up in the ER for, and it's not a fun experience. I've been in there. I've never gotten put on a BiPAP or CPAP or anything, but I've certainly been given supplemental oxygen and albuterol treatments um, to help relieve my exacerbation, and it's scary. When you have one of these diseases and it exacerbates, you get incredibly anxious because you can't breathe no matter how hard you try. So it's terrifying, and you know when you see these patients in the ER, and you have to realize that you need to do the best you can for them because they will progress quickly, and it's terrifying for them. So, and frequently these are diseases they've been dealing with their entire life. But exacerbations are, while they may be the most common thing we see, they never get easier to deal with.
I'd argue they get harder because all it takes is one little trigger, and then, like you were kind of saying, they put the worry in you, and then you just get worse and worse and worse and worse, and it's just like, granted, as you get older, you learn to deal with them a little bit better, but still, once they get to a certain point, it's just like they just escalate so quickly.
Hmm. Yeah,
And if I
absolutely.
remember, in one of our classes that we had this semester, one of our guest speakers, he talked about exacerbations. At least I think it was COPD or asthma. I can't remember exactly, but after you have an exacerbation, your lungs don't quite heal all the way, and so you're just a little bit worse each time you have an exacerbation. So it's important for us to remember, if that is the case, that we need to help these patients out with these exacerbations and avoid those triggers that give them an exacerbation of their symptoms and their obstructive disease that they have going on.
Oh yeah, absolutely. I mean, one of the biggest parts when you see these emergent exacerbations is after you've got them stabilized is education. So education's a huge, huge part of being a respiratory therapist with these patients. So if you can properly educate them on what to do and kind of manage them, then you they'll have an easier time, and hopefully the goal is to have them to have less exacerbations in the future.
Definitely. Those can be like tough conversations to have though with patients. A lot of the times, they recognize they have a problem but still aren't totally willing to change.
Oh, sure.
Yeah, like most of them are actively smoking, and I've never smoked, but I imagine it is hard to quit. And they know it's going to kill them. They Some of them just don't want to quit, but some of them are trying, and that can be stressful as well. I just wanted to chime in on another thing. I had a preceptor that was talking to someone who had a COPD exacerbation that was like going home. We were doing like discharge teaching, and she was recommending to like switch out their nasal cannula, get a different toothbrush than what they were using before their exacerbation. I think it's just kind of like start new and have clean equipment in case something that they were using um, expedited that.
Yeah, that's actually a really good idea. I'll have to keep that in mind in the future.
I like to think of it like when you when you do have those conversations, like I used to think like, oh, how hard could it be to quit smoking? Like it's bad for you. Just knowing that would like get me to stop. But then I also think like myself, like I may not smoke, but I'm definitely addicted to other things. Like I love to eat out a lot. And there's times when I'm like, oh, I need to stop eating out. And I can for like a week or so maybe. Just like any smoker could quit smoking for a week. Like I don't feel like that's hard, but then it gets to a point where I'm like super tired or I get stressed out or something happens and then I'm like, oh, I'm gonna go get me a hamburger or something. And it's just like relating that to myself is like I understand how hard it can be to quit smoking. It's like I don't blame them, but I recognize like it's tough. but it'll be beneficial for you.
Oh yeah.
I agree, Trevor. I crack my knuckles when I'm stressed. I don't know why. I haven't done it since I was like I didn't do it until I was about 20 years old. And now whenever I'm like studying and something just doesn't make sense, I just pop my knuckles all the time. And I don't know why, but I hate it. I just hate the sound of knuckles cracking, but I just do it anyways.
Oh yeah.
It's just those habits that we develop.
Yeah.
Habits are especially tough to break, and when you have that, physical need along with the psychological need, it's impossible almost. I mean, one comparison I've always heard thrown around for nicotine specifically, and I'm not sure if this is entirely true, but I'm going to say it here because it's what I've always heard, is that the only substance that's more addictive than nicotine is heroin. So,
Mhm.
and when you talk to a lot of smokers out there, it's what you see. So you have people that try tons and tons of time, and it's only until they get, replacement therapy or, just any amount of support that they can get that they can actually, start to kick it.
Yeah, I think Drew actually did a project on smoking cessation. And I think it takes like the average person 7 attempts before they're like actually successful at quitting smoking.
Yeah, the research I found, it said 8 to 11 times, and I talked to my father-in-law. He actually never smoked, but actually all of his siblings have, and most of them have since then quit. But he said their biggest thing was just once they realized that they wanted to quit, then that's when they would make the necessary steps to do it. Whether it was they found, a religion that helped them, or they found a really good support system, or they realized, crap, this habit is a fatal habit and I need to knock it off if I want to, live longer with my family and all that. Um, but yeah, it's good to let the patients know that when we are trying to help them with this, to have a good support system, to someone that can help hold them accountable and maybe sympathize with the struggles that they're going to be going through.
Yeah, and I think if you quit anything that you've developed a habit for like a long time, like say somebody like they drink a coffee or a diet coke like every time they're at work, and then all of a sudden they don't have it, they usually have like the worst headache of their life. Like they usually have terrible headaches. Or I've seen people try and quit alcohol cold turkey, and their bodies just like they don't handle it very well because they're just been so used to this. So I can kind of relate more to like people trying to quit smoking, because I bet you it takes a toll on them as well if they just up and quit when they've had a 5+ years smoking. Like their body is just kind of accustomed to that now.
Oh yeah, absolutely. It's a long process, but we want to do our best to actively promote it. So
Right.
and we'll go over the methods that we actually promote smoking cessation and all that in a future episode. But yeah. So now with any emergent condition, there's always the chance of death, and it's an unfortunate subject, and this is the part of the podcast where we get kind of sad about these things, but it is important to talk about. A lot of patients don't get the ability to choose how they die, and personally, that is one of the rights I think that patients should take advantage of the most is choosing how they get to die, especially hospice patients. And one of the biggest documents for this is the advance directive. Tom, you seem to know quite a bit about advance directives. Are you willing to talk a little bit about it?
Oh, totally. I I don't know. I may be a little jaded when it talks to like death. Like, don't get me wrong, it's still a sad topic, but I've dealt with a lot of cases on that. I just want to kind of throw this out there. I think a good way to cope and handle death is to figure out for yourself what you think happens when you die, and then pretty much come to terms with that. Whether that's through religion or if you think that's just the end. I think that's the hardest thing for patients and family members is um, don't want to let go. I can understand that, but I think it's easier to accept when you come to terms with what you think happens when you die. But, advanced directives, there's actually a lot of different routes that we could go with this. This is pretty much just respecting the patient's wishes with um, if certain events were to happen. Of course, we don't want any of these things to happen, but we plan for the worst and hope for the best. I think um, my colleagues here are probably getting sick of me saying that, but yeah, we obviously we ask the patient. It can be a hard topic. I don't know if it's because I'm jaded or if I've just been in healthcare so long, but I don't have a problem talking to patients about this. But it's always interesting to talk to people and see like their what's the word trying to think of, like their manner just changed, like their facial expression, and like this is something that people haven't considered. Obviously at hospitals we want to try and save everybody, but I feel like a lot of people, they don't connect that my loved one may not leave the hospital alive. um, like I said, we'll do the best care that we can, but sometimes we can only do so much. um, so that's why we want to have this conversation with uh, patients is and maybe their loved ones. Like sometimes patients, they relinquish their sorry their decision making to a loved one, whether that be a spouse or a child, for example. But I think it's best when the patient is able to make the decisions themselves. So we need to have this conversation as early on as we can with the patient to be like, if your heart were to stop breathing, do you want us to do chest compressions? If you were to stop breathing, do you want us to intubate you and put a tube into your trachea so that we can have a machine do the breathing for you? Um, and and at what point do you want us to potentially keep the ventilator going, or when do you want us to shut it off? Like some people, they wish to only be on a ventilator for a couple weeks, or some people say, if you, as long as you guys think I can come out of this, keep me on a ventilator. But if we have somebody on a ventilator, usually we have to administer nutrition somehow, which is usually through a tube feed. And some people want that, and some people don't. There's different types of tube feeds that we can do. The most common one is usually an NG tube, which is a nasogastric tube, and that usually goes through the patient's nose and into their stomach. And we usually administer nutrition through there, which is usually, we call it tube feeds. It doesn't smell very good, and I actually have tasted it because I was curious. It's what I imagine a vanilla protein shake and bone meal combined together tasting like. But since we bypass your taste, like your tongue, you don't taste it. So that's probably a good thing. But there's also a peg tube that we could um, insert into a patient's, and it's just a tube that goes straight to their stomach, and we just pump the food in right there. Some patients want that, some patients don't. But that's why we need to have this conversation so we can best respect a patient's wishes. I mean, I feel like a lot of patients lose dignity just being a patient at the hospital because usually they're not allowed to wear the clothes that they're used to wearing. Their butts usually hanging out for everyone to see. They have to have help up to the bathroom. Sometimes they're in a situation where they need help eating when that wasn't a situation before. It's a huge adjustment for most people when they become a patient at the hospital. So we need to be sensitive to that and respect their wishes. But um, yeah,
Also,
but it's also good to. Oh, go ahead, Trevor.
yeah, I think it's definitely respecting the patient's wishes, and that's where advanced directives are nice. But I also think it really helps the family deal with whatever's going to happen. Some families do feel bad, like, and they don't want to like be the ones to make the call for the patient when it might be time to just let them go, or they might already be I guess mentally not there, but like they're only alive because machines are keeping them alive. It's at that point where an advanced directive can come into play and just like take all the guilt away from the family. In a sense, it can just let them know like this is what that your family member requested their end of life care to be, and so you don't need to feel guilty like withdrawing all the support. So in that sense, like yeah, it honors the patient, but it also honors their family and like kind of relieves them of the guilt.
Yeah,
Yeah,
I totally.
if I can interject real quick, where the floor that I work on, I deal a lot with end of life, and I've been on both sides of the family where they don't know whether to just end cares for the loved one. They know it's or because they didn't have an advance directive, they don't know what it is, and a family member feels like they are either like killing or murdering their own family member when in actuality it's not really what's going on. And I feel like we as healthcare workers can feel the same way if we don't know what this patient's wishes are, and those advanced directives help us as well as the loved ones to understand this is what the patient wants. He or she is ending this the way that they want to, and they have that dignity to have it that way.
And I mean, it is a stressful situation, and I know it's something that not everybody deals with regularly. I think it affects healthcare workers too, like also, and I think especially in respiratory therapy, like we are known for withdrawing life support, like taking people off of ventilators and stuff like that. And I think there's a lot of respiratory therapists that think, "Oh my goodness, I am killing this patient." But I've said this also again, that what would have happened if we didn't intervene? Like if this patient wasn't on a ventilator, they would have passed on their own a long time ago. So we need to make like I feel like we need to specify and make sure that people understand that withdrawing care is not. I wouldn't say it's killing it's not. What am I trying to say? It's not us like meaning to kill the patient. We're respecting their wishes. This is what they want, and I think healthcare workers and family members also. Um, they all need to take um, comfort and confidence in that we are respecting this patient's wishes, and this is what they really want. Um, and yeah, especially it's kind of frustrating because you're supposed to renew your advanced directives every so often. I don't remember the exact time frame, but sometimes when that window closes, like that when the advanced directives is active, that's when it gets sticky with the family having to make the calls, and that just those situations drive me crazy
I
because
believe it's every 10 years.
every 10 years, I thought it was actually shorter than that. Like I thought it was
I
every
think it's
2 or 3.
recommended like no more than every 5, but I believe the actual legal capacity is every 10 years.
Yeah, and
I'm not sure on
I
that.
think family members should be aware of what their grandparents or parents want, especially if they're like older. I've personally had this talk with my wife. I told her if medical staff asks, I want to be a full code until our youngest kid is 18. Some people say that's kind of morbid, that I could still be pretty young when our youngest kid is 18, but that's really what I want. If anything were to happen that I can't make my own decisions, my wife knows what I want, and I know what she wants. If anything were to happen, I've had that talk with my parents. Like I said, I am so comfortable talking about this with anybody. Um, I'm just weird like that, but it's a sticky situation when family has to make decisions for the patient. Like I feel like you should have talked to them about what they want, and take confidence in what their wishes are and respect them enough to let those be carried out instead of fumbling around with your own thoughts of what should happen. Like it also makes it hard on healthcare workers when family keeps going back and forth. Like, I want you guys to do everything you can. Oh no, I don't want you to do this. I want you to do that. Yada yada yada. It's just don't be scared to have that conversation. And I think it's best if we have that conversation, like I said, as soon as they walk through the door. I even think doctors mainly have this conversation when patients come through the ER, and I just think that's the best practice before the patient like worsens and they're not able to make decisions on their own.
Yeah, that's a great point. These things are they're advanced directives are tricky, but they are super important. I personally have informed my family what I want. Should anything happen.
Yeah, and it just kind of goes back. Like you need to realize that nobody gets out of this life alive. Like it's just something that happens, and I think everybody should have the opportunity to decide what they want. It and there are situations where people don't get to make that decision, which is kind of sad, but that's just life. But I think it would be best if everybody knew that's close to you, like what you want, if something were to happen.
Absolutely, I agree. But that is going to be the end of this episode of Don't Hate Ventilate. I know it's a bit of a morbid end, but it's an important topic. So
Yeah.
we will see you next time on Don't Hate Ventilate. Check you out then.